Good evening. This is Dr. John Bennett, broadcasting from Miami. Tonight we have another in a series of Parkinsonism hangouts with Dr. Abdul Rana, a neurologist from Toronto. He's a world-renowned medical educator in the field of Parkinsonism. And tonight he's going to be talking about genomics and Parkinsonism. Good evening, Dr. Rana.
Good evening, Dr. Bennett. How are you doing tonight?
Very good. Again, no more snow up in Toronto, correct?
It's melting quickly.
Oh, it's melting already. Wow. It would melt very quickly here, too. We have a cold snap in Miami. Anyways, okay, I'll start things off with a question. Can you give us some historical background of the genetics of Parkinsonism, please?
Threat has been detected.
The history of genetics of Parkinson's disease is actually quite interesting. In 1888, Gowers thought that a small number of cases of Parkinson's disease could have a familial basis. In 1926, Bell and Clark, they described about 10 kindreds with shaking palsy, and they thought that the hereditary factors were important in these cases. In 1937, Allen described about 25 kindreds. In his cases, the interesting thing was that they all had a single autosomal mutation, and they seemed to be autosomal dominant. In 1949, Jones described 8 pedigrees, but they had atypical features. And then in 1954, Van Bogart, he described a kindred in which not only symptoms of Parkinsonism were there, but there were symptoms like ALS or a combination of Parkinsonism and ALS. Then in 1955, Beeman described early onset Parkinsonism, and these patients also had atypical Parkinsonism features. In 1963, Kovarik also described several kindreds, which also had extrapyramidal features. But in last 2 decades, there has been a lot of progress in the genetics of Parkinson's disease, and today we know much more than we knew before.
Very good, doctor. What are the genetic mechanisms which play a role in familial Parkinsonism disease?
There are a large number of cases of familial Parkinsonism, but the 2 main categories are synucleinopathies and taupathies. So how synuclein, the alpha-synuclein protein, and the tau protein cause neural degeneration, it's not exactly known. But there could be a loss of function in these mutations or gain of function. And future research in the molecular genetics might help us to know more how is the interaction of these genetic factors with the environmental factors. As I was talking before, in last 2 decades, there has been a lot of progress made, and genes for alpha-synuclein, which was found out in 1997, and then gene for LRRK2, which is leucine-rich repeat kinase 2, they were determined. And these genes have mutations which are carried on in an autosomal dominant fashion, and these mutations are responsible for quite a few cases of familial Parkinsonism. Some genes like PARK gene and the DJ1 and the PINK one, they cause the autosomal recessive type of Parkinsonism. Now, the alpha-synuclein is a protein, and it plays a role not only in the genetic cases, but also it is thought that it may play a role in some of the sporadic cases of the Parkinson's disease. Although each mutation seems to cause the features of Parkinson's disease in a small number of families, but these pathways, the molecular pathways, could be common between various inherited forms of Parkinson's disease. Only a minority of patients who have clinical features of Parkinson's disease and they have family history of Parkinson's disease, they follow a Mendelian pattern of inheritance. In these patients who follow a Mendelian pattern of inheritance and they are familial, So the age of onset of Parkinson's disease is much earlier than the other patients who are sporadic. And there are no differences in the clinical features of these patients, whether they are familial or they are non-familial. And these patients who have familial Parkinsonism, they also have a neurodegeneration in the dopaminergic system in substantia nigra. However, the pathology may be somewhat different. In some types of familial Parkinsonism, there could be a selective loss of dopaminergic neurons, and in other cases, there could be a more widespread loss of dopaminergic neurons. In majority of cases, the Parkinson still remains a sporadic disease, but the genetic factors in those cases, which apparently seem to be sporadic, it may play a small role, or at least some role. And also, genetic research has helped us to understand more about the clinical aspects and the pathological, as well as the genetic heterogeneity of Parkinson's disease. Sometimes a single gene defect may cause a diverse type of phenotype in Parkinsonism. On the other hand, the diverse type of mutations or different mutations may cause a clinically similar Parkinsonism. Now, the relative risk of having Parkinsonism or developing Parkinson's disease go higher if someone has a first-degree relative, or if they have a sibling or a child parent pairs. The relative risk is between 3 to 4 in these patients.
Very good, doctor. Does it follow a Mendelian pattern of inheritance?
Yeah, as I said, only a small number of cases who have clinical features of Parkinson's disease and they have a family history, they follow a Mendelian pattern of inheritance. Most of cases don't follow the Mendelian pattern of inheritance, and they have so complex mechanism that we are not able to understand as of yet. However, in future, as research goes more advanced, we may understand these mechanisms. The genes which are located on the chromosomes, they produce the protein, and the changes or the abnormalities in the production of protein, the mutations, they cause the abnormal protein, which this abnormal protein now accumulates in the neurons and causes the neural degeneration. Typically, when you look at the Mendelian pattern of inheritance, if it is autosomal dominant, then it means that 50% of the children of one affected parent should have the disease. Whereas if it is a autosomal recessive condition, then 25% of the children of two carriers, the parents who are both carriers, they should manifest the disease. But that does not happen typically in most cases of Parkinson's disease. Now, the Parkinson's disease itself is a heterogeneous group of diseases, although it is a clinical and a pathological definite separate entity, but still within it we see so much diversity, such as some patients would have more of a tremor and they would have less of bradykinesia and rigidity. On the other hand, the other patients would have more of bradykinesia and rigidity, and they would not have tremor. And this does implicate, in terms of prognosis, classically, patients who have a tremor dominant, which means that their tremor is much more apparent. They have very mild bradykinesia or rigidity. They have much better prognosis than patients who don't have a tremor, but these patients have more of bradykinesia and rigidity, which sometimes is referred to as akinetic rigid type. So beside the diversity, there is no other difference. Like they would have a young age of onset if they are familial, but otherwise you can't tell from the familial Parkinson's, or you cannot tell the familial Parkinson's from the sporadic, because the clinical features are about the same. There are many different cellular mechanisms involved in the causation of these problems, such as protein aggregation, mitochondrial dysfunction, or oxidative stress. At this point, there are about 10 to 15% of the cases who are likely familial. They have younger age of onset, and there are many different genes which have been found out to be involved in many different mutations. However, among the common ones is the LRRK2, the leucine rate repeat kinase, which is autosomal dominant. It was initially found in a Japanese family and is mapped to chromosome 12. This is the most common form of the inherited Parkinson's disease. But as time goes by and research is advancing, we would find out more, and there could be more mutations and more types of familial Parkinsonism could come to the scene. The alpha-synuclein is the first one, which was found in 1997. This protein is produced by the gene, which is a gene for alpha-synuclein, and this is considered a basic, or the first described familial Parkinsonism, and this alpha-synuclein, it accumulates in the Lewy bodies and causes the neural degeneration. These patients have typical levodopa-responsive Parkinsonism, which could be inherited. In some cases, it may have a role in the sporadic type of Parkinson's disease as well.
Doctor, in today's clinical practice, genomics is assuming a larger role.
It is.
Do you find yourself advising patients to get genetic profiles in young Parkinsonism patients?
This is an individual decision because every person is different. So when we see a patient who is relatively younger, 40 or less, or if they have a family member or a first-degree relative or a parent who was affected with Parkinson's disease, so we do discuss that their Parkinson's could be genetic. Patients also do a lot of reading on web, and they have some idea that it could be genetic, and so they may ask us questions sometime. So with respect to the routinely genetic testing, we indeed don't do it because of several reasons. One of the reasons is since there is no neuroprotective agent. So if there was a neuroprotective agent, then we could test family members or relatives or children, and we could use that to prevent or delay the onset of disease. So testing and finding out would not delay the onset of the disease. And then because it's not a curable condition, it's a treatable condition, but there's no cure. If there was a cure, then you can test these patients and use the cure, and then the problem would be solved. But because it's a chronic condition, so some patients they don't like to know. They say that, well, you know, they're like their family members or kids. They would say that you know, even if I am supposed to develop Parkinson's disease in future, because there is no cure or a neuroprotective agent, why should I try to find out? It would give me just stress, and any little symptom would happen. I would think that this is due to Parkinson's disease. The other patients are anxious, and they would like to know that how their future may look like, because it's still not 100% that if a person has a mutation, they would develop Parkinson's disease in future, or the other way, that if they have a young onset Parkinson's disease, they would have a mutation. So it's not like 100% relation. So it's an individual decision, and some patients feel, or some of the patient's family members, they feel that they should be tested. However, in our experience, most patients don't want to be tested.
Very good, doctor. Anything else to add before we close on tonight's topic?
The genetic is becoming very interesting, and it's developing more, and hopefully in future we would have much more information and much more knowledge to share about this topic, and not only about the risk of having a disease, but also about the effect of medication. There could be certain genetic types of Parkinsonism which may respond to certain medications more than the other medications, and finding out these things could mean a lot to the patients as well as physicians. I suppose if we find out that a certain mutation is more responsive to certain medication, then the treatment would become more simple, more easy, and hopefully more effective.
Very good. Thank you, doctor, for spending the time tonight and educating us about genomics and Parkinsonism. For the rest of these educational videos, go to parkinsonism.tv. And also, we should be on tomorrow night with another educational video on Parkinsonism with Dr. Rana. Thank you very much, Dr. Rana. Good night.
Thank you. Good night.